Hello there. We are going to be, I'm going to be lecturing on the skeletal system tonight. So without further ado, here we go. These are the learning objectives. Take a quick moment to look over those if you would be so kind. All right, here we go. So this is the skeletal system. Let's take a quick run through these here. Starting at the top and working our way around, there is the cranium, the facial bones, the mandible. There are a lot more bones in this. This is just a brief overview. The sternum in the middle of the chest, costal cartilages off of that, the vertebral column in the back, the ilium, crest of the pelvis, the sacrum moving in towards the pubic symphysis, which we'll come back to, the calcaneus or heel bone, metatarsals here. Now you will notice there are metatarsals in the foot and metacarpals in the hand, and there are also phalanges distally on the foot as there are phalanges distally on the hand. The shoulder girdle up here comprised of the clavicle and scapula. Humerus and the upper arm bone corresponds to the femur, the large bone in your leg. And then you have the radius and ulna in your lower arm, just like you have the tibia and fibula in your lower leg. The radius being the large bone that runs back from your thumb. The ulna is opposite that. The tibia being the large shin bone, and the fibia is behind that. And of course there's the kneecap, the patella, and then of course your ribs. So the skeletal system can be broken into the axial and appendicular. The axial consists of the skull, spinal column, and the thorax. The appendicular is comprised of the shoulder girdle, arms, hands, pelvic girdle, legs, and feet. Let's start with the axial skeleton. There is a skull. There are 8 cranial bones, 14 facial bones. In the spinal column, there are 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and 5 fused vertebrae in the sacrum, and the coccyx at the very end is 4 to 5 depending on the individual, and it varies from person to person. So here's the skull. With the sutures, we will be going over the sutures as one of the ways that bones are joined together. You don't need to know these, but I do want to at least expose you to them. The coronal suture, squamous suture in your temple. These are essentially where bones have grown together. And mastoid process, where jaw muscle, the powerful jaw muscle is attached to. That's what all you need to know at this point about the skull's makeup. In the vertebral column, we have the aforementioned cervical vertebrae, C1 through 7, the thoracics, T1 through T12, the lumbar, L1 through 5, down to the sacral and the coccygeal vertebrae. Axis and atlas are the last 2 bones on top of the cervical column that the skull sits on top of, so it can move from side to side on top of the atlas and axis. And there are some other parts of the spinous processes sticking out from the spinous, from the vertebrae. And there's that word foramen. Anytime you see a foramen, that means there's going to be an opening. In this case, the foramen is for a spinal nerve to exit or enter. And we actually will be returning to something that concerns the intervertebral discs, where the between the vertebrae there is a cartilaginous band holding them together and providing cushioning. In the thorax, you have 12 pairs of ribs and the sternum. And that's it. So axial skeleton. Now we will move on to the appendicular skeleton. You have the shoulder girdle, which is comprised of both the clavicle and the scapula. Here we have the scapula and clavicle. We're not going to worry about these other things right now. Moving down to the arm bones, the humeruses, humeri, ulna, radius, carpals, moving distally to metacarpals and all the way out to the phalanges or fingers. The pelvis has 2 pelvic bones. There are 3 fused bones, actually, the ilium, the ischium, and the pubis. So those look like this. We have the ilium, the ischium down here in blue, and the pubic down in this area. Where the 2 pubic bones come together, you have the pubic symphysis. That is a very thick cartilage that joins the 2 halves together. In the leg, you will start at the femur and move downward to the patella, tibia in front, fibula, the much smaller bone behind that, and the tarsals, metatarsals, and phalanges, very similar to the upper extremities, just larger. So here are the roots you'll want to learn for the bones and joints. Again, feel free to pause these and work your way through them, or pull up the PowerPoint slide that's provided in Blackboard. Take a look at them at your own pace. So bones are formed initially. They all start as cartilage, and then ossification or mineralization with calcium and phosphorus begins at birth and continues all the way through to adulthood until all the cartilage has turned into bone that is going to turn into bone. There are 3 types of bone cells. There are osteoblasts, which produce or build the bone. I always keep track of the B for building. Then you have osteoclasts, which break down, and then the cells in between are the osteocytes, or when they're mature. So when you have osteoblasts working harder, you are having more bone produced. When osteoclasts are doing their job, more bone is being broken down. When you're in complete homeostasis, the osteocytes are the prevalent form of bone cells. And resorption is destroying bone, and that is the jobs of the osteoblasts. A structure of a long bone. A long bone would be something like your humerus or your femur. We'll be looking at the femur as an example in this case, pretty much. The diaphysis is the long shaft part of the bone, and there's yellow marrow inside of that shaft, inside something called the medullary cavity. The epiphysis is the end of the bone, and that has spongy bone tissue. This is where the red marrow is contained, and a lot of red blood cells are produced in the red bone marrow. And the whole thing is covered by a thin layer of cartilage. The metaphysis is the region as you go from the diaphysis to the epiphysis. So it's kind of an in-between. It's not really clearly demarcated, but as you move from the diaphysis to the epiphysis, you have this transitional area called the metaphysis. And this is where the epiphyseal plate is, also known as the growth plate, that keeps extending out and out as a person is still growing. And at some point it calcifies when the growth is done, and a person won't get any larger from that point forward. The periosteum is a layer of fibrous tissue that is outside the whole of the bone to nourish and protect it. And bone cells are made at least partially in the periosteum. So here's that structure of the long bone in visual form. We have the epiphysis up here with the spongy bone inside. We have the diaphysis in the middle here with the, let's see, yellow marrow. And we have the epiphyseal plate in the metaphysis. The diaphysis, or long bone, is comprised of the strong, compact bone for supporting the weight of the entire structure. And then, of course, you have arteries and veins in the middle providing nourishment from the inside for the yellow marrow. So there are three different types of joints we're going to be looking at. The suture, like the one we saw in the skull, is very, very strong, essentially fused bone with a very tough fibrous connective tissue. A symphysis is slightly movable. If you remember when we were talking about the pubic area, the pubic symphysis is one of these. It is somewhat flexible, but it is also made of fibrous cartilage and can flex just a little bit more than a suture. And the synovial joint is a freely movable joint. When you're talking about these, we're thinking about knees, we're thinking about shoulders, any other of the joints that can move around. So suture, symphysis, and synovial joint. So let's take a closer look at synovial joints. There is synovial fluid that is inside of the joint that is a cushioning and lubricant for the joints as they move around. This is made in or by the synovial membrane. There are ligaments that connect the articulating bones, whereas the tendons are attaching the muscles to the bone. So ligaments connect bone to bone, tendons connect muscles to bone. So here are some more keywords. Take a look at these and become familiar with them. Okay, so let's look at some clinical aspects of the skeletal system. Orthopedics is, of course, the study of skeleton and muscular systems. An infection can set in. Osteomyelitis, again, we see that suffix itis, or inflammation, formed by bacteria infecting the bone. Tuberculosis is another organism that can get into the bone. And if it gets in the spine, a tubercular infection of the bone is Pott's disease. You can also break the bone, and it's caused by trauma by and large, unless there is some underlying condition that causes weakness of the bone where they spontaneously can break. But by and large, it's a bone trauma. Bones to break. They are rated by their location and the severity. A closed fracture is when the skin stays intact, and an open is just like it sounds. That is when the skin is broken by the underlying bone when it breaks. So we have a closed fracture right here. The Achilles fracture in a wrist. That's probably someone trying to catch themselves. That would be the type of fracture you'd see at that point. Here's a comminuted or a crushing break. Here's a compression fracture in the spine, too much weight being applied to the spine and has broken the vertebrae in a vertical pressure. There's a green stick where it's partially broken on one side of the bone, the other side has stayed intact. Impacted, that is when it has gotten jammed and broken from the jamming. An oblique goes at, as indicated, at an angle through a bone. An open, here you can see the bone is broken through the skin. The pot that we talked about with tuberculosis has set in to the infected bone and cause a break. A spiral is one that winds around the bone like so, and transverse again all the way through the bone at a slight angle. So to treat the fracture, you want to realign the bone. If there is no surgery, it's a closed reduction. If you do need to place pins to keep the realign the bone, then it is an open reduction. The closed is always preferable to the open when it comes to broken bones. And then the healing phase, you can use a cast to immobilize it to allow the osteoblasts, the builders, to form no new bone tissue and knit the bone back together. In osteoporosis, there's a loss of bone mass. Women over 50 are the most susceptible to this problem. The best way to prevent this is to get adequate calcium, vitamin D, and phosphorus when a person is young, to lay down as much bone tissue as they can. So as it naturally becomes less and less as a person ages, they're less prone to ending up with clinical osteoporosis. And also weight-bearing exercise stimulates the bone to grow stronger as well. So osteomalacia is a softening of the bone tissue. That happens when there's not enough vitamin D, is the primary dietary cause. It can also happen in renal and liver disorders. And then intestinal disorders where there is a malabsorption pertaining to vitamin D, particularly, that can certainly cause an issue with osteomalacia softening. In Paget's disease, or osteitis deformans, this happens in aging. Bones get actually overgrown and thick. This is not good when they are out of control, and usually is the bones of the axial skeleton, if you can remember the ones that bones that were involved in the axial skeleton. Cancer can also develop in bone tissue. An osteogenic sarcoma is very malignant and usually happens around that epiphyseal growth plate and the metaphysis. And you can often require amputation because it is so aggressive. And a chondrosarcoma is in the cartilage. And again, this can cause a need for amputation as well to get the cancerous material away so it won't spread. So the first signs of bone tremors: pains, easy fracturing, and if you take a blood draw, you can see lots of calcium and alkaline phosphatase. So there are two main types of arthritis. There is the more common osteoarthritis, which is usually a disease of aging and overuse. The bone and cartilage particularly starts to degenerate with time and use, and you can end up with bone and bone, and the bone will actually start trying to grow once there's a cartilage in the way, and they start rubbing against each other, and you end up with osteoarthritis, usually on one side of the body. If not exclusively, then certainly worse on one side of the body or the other. And treat it with pain pills and physical therapy. The other type of arthritis is rheumatoid. This is an inflammatory disease, and it often involves the overgrowth of synovial membrane, too much synovial fluid, and you get joint swelling. They blow up like a balloon. And ankylosis can be the, or degeneration of the underlying bone tissue can be the result of rheumatoid arthritis. So the treatment of this is rest, physical therapy, again, pain pills to help with functioning. This is a picture of someone with rheumatoid arthritis. You can see the bending and swelling that is developed from that overgrowth of synovial tissue and buildup of synovial fluid, and the resulting deformation of the underlying joints. Gout is when there is too much uric acid. If that uric acid builds up in the synovial fluid, you can get uric acid crystals, and that causes extreme pain. The drugs that use to treat it attack it in one of two ways. Either it can suppress the formation of uric acid, or it can increase the elimination of uric acid in the kidneys. Either way, if there's less uric acid, those crystals can dissolve and come out of the joints and resolve the symptoms. So to repair a joint that's undergoing something like osteoarthritis or other underlying issues with cartilage, you can use an arthroscopy to take a look. Here you have an eyeball looking into that to see what's going on in the joint. You have arthroplasty, there's that suffix again, is the reconstruction of a joint, and in extreme cases you can have to go arthrodesis to actually fuse the joint. A lot of times vertebrae in the back will need to be fused if there is enough degradation of the connective tissue. In ankylosing spondylitis, usually in males, and I can't tell you why, it's just the way it is. That's when joint cartilage between the vertebrae is destroyed and they start to calcify and lock up. It starts in the lumbar region and works its way up towards the cervical region. And these are less common terms. Spondylolithiasis is a forward sliding of vertebrae, and that will cause a pinching of the nerves and a lot of pain. And spondylolysis is the degeneration of the structures that are stabilizing their vertebrae, and they slip around willy-nilly, for lack of a better term, and cause a lot of pain and instability. When you get a herniated disc, there is a mass inside of the disc that can stick through and start pinching on nerves. Again, we're looking at the lower back and the lumbar region oftentimes, and skip through the thoracics up to the cervical regions. Can happen when you damage a vertebrae from lifting something improperly, and you can actually have to go in and take out some of that disc to keep it from pressing on the nerves and causing all the pain. So what that looks like is right here. So around the body of the vertebrae, you have an annulus fibrosus, very tough connective tissue that can rupture when you lift something that's too heavy, and this will extrude out and press on a spinal nerve, and that's where you get the pain from a ruptured disc. So there are three curvatures of the spine you can look at. Kyphosis is in the thoracic region is like this. That's colloquially called a hunchback. Lordosis is sway back in the lower region down here. Pardon me. And scoliosis is the S-shaped curvature of the back looked at it from the dorsal side. So here are some terms that we've just covered. Go and make sure that you have a firm understanding of these terms. So there are a couple of interesting terms, and there's some drugs that are used to treat diseases of the skeletal system. Bisphosphonate, which is Fosamax or Actonel, are used to treat osteoporosis to increase bone mass. And there's also selective estrogen receptor modulator, such as Avista or Raloxifene. This also helps prevent bone loss after menopause. And NSAIDs are non-steroidal anti-inflammatory drugs. We're talking ibuprofen and the other drugs like that, aspirins and NSAID, and they help with pain and inflammation.